selective dose distribution, and the number of patients who are treated as well as increasing with carbon ion therapy, so we know more and more about the outcome of this method as well as. Unfortunately, especially if carbon therapy, a huge synchrotron is needed, and of course if there is a huge investment, then there are a lot of rooms which are parallelly used. But recently, for proton therapy, the single room facility has decreased remarkably the price of these proton facilities. So in the recent years, there are a lot of facilities have been installed with rotating memory, with raster scanning technique, which provide a good dose delivery, and more than 1,500 patients have been treated, but unfortunately, to this very nice method, only less than 2% of the whole patient population who needs radiotherapy have access. So there should be done something, and hopefully we will learn about that. So thank you for your attention. And now spray, or yes. Do you have some questions?
Question.
Yeah.
So there is one slide you use some needles to create holes on the tissue. Right? You make a bunch of holes. And you said that the holes are not very ideal, the positions.
Yeah.
I saw that it's just a bunch of needles. Why don't you use something to fix it? Like fix the bunch directly, you know.
Yeah, so you can imagine like this, but in the reality it doesn't work. You cannot, but actually you test something, because there are a lot of efforts, a group of mathematicians and physicists have worked on the automatic insertion of these needles, yes. There was a plan, but in my knowledge, it is still in experimental status, because there are a lot of blood vessels and bleeding may occur, and there are a lot of different shape and different problems of the patient which may occur. Sometimes the surface is not straight and not intact. Sometimes there are ulceration which is already changing day by day, and you plan the insertion, the automatic insertion on a needle, and it turns out that it is completely the other way around. There are robotic surgery as well as, and robotic brachytherapy as well as, but not yet well spread. But it's a good point, yes. So, yes?
I want to ask about the usage of brachytherapy in uveal melanoma treatment. So, how long does the soothed radiated metal stay in the eye of the patient, and does the patient have to be hospitalized during the period? Because, I mean, if it's radiation and if he's walking around, doesn't it radiate others?
Yes, it's a quite difficult issue, because these cathodes, which are produced in different shapes. There are, for example, a cathode which has a hole in it in order to be able to sew it on the surface of the eye, at the back of the eye, and nervus opticus will come out in the middle. So it can be in different positions sewed, and the isotopes has a certain activity, and the whole thing has to be very safely handled, has to be regularly analyzed, activity measured, and depending on the activity, there are plans which are done. Depending on the activity, to achieve a certain dose, there is a certain defined time which is staying this applicator. The patient can move, but it is not a very nice thing. So I have seen a lot of such like things in Essen, in Germany, and there were a special group of physicists who were measuring this beta ruthenium from the ruthenium released beta radiation electrons, and they had a special dosimetry for that, and they have defined the resting time, how long it should be rest depending on the activity decrease of the different devices, and it had to be stored very carefully. Sometimes the ophthalmologist had some interesting movements with them, but finally the patient theoretically could move, but because of the radioprotectional aspects and because of any time can happen something, a bleeding or something like that, they are hospitalized during from 8 to 12 days. So at maximum 2 weeks. And they are hospitalized, of course, in a special care unit where the radiation is well controlled.
Thank you.
And they should not kiss anybody with them. I'm sure. Nevertheless, the electrons has not a long but
you refer to spatial selectivity and technical development in this part. So, about which types of radiations do you refer?
Yes, it is depending to what we are comparing. At the beginning of radiotherapy, you have seen there is only one tube, one size, and that's it, and one direction. And I refer the possibility of using multiple fields, multiple directions, multiple field size, or defining the field size from really a pencil beam from half a centimeter of diameter up to 40 centimeter by 40 centimeter. And in the orthovoltage era or at the beginning of the cobalt era, we could use only quadratic fields. And nowadays, of course, it is adapted to the tumor size, to the target size, and we can use multiple fields, and we can use even moving fields, rotating fields. There are a lot of technical developments, for example, a flattening filter which absorbed a lot of amount of particles, and now it is possible to calculate the dose without flattening filter. The flattening filter free technique which reduce the delivery time, for example. So these are the development as well as the possibility of imaging during the therapy or prior to the therapy. There is a built-in cone beam CT, for example, or orthogonal imaging technology with really TV imaging, good quality imaging, which can be acquired prior to each fraction. So the delivery, the accuracy of the delivery, and the planning itself, and the dose distribution quality could be enormously improved with the new techniques. The volumetric arc technique is the latest one. And there are, for example, multi-collimators with 1 centimeter leaves, with half centimeter leaves, or with a possibility to build in at a smaller region in the middle, 2.5 centimeter leaves. I mean 2.5 centimeter in the isocenter level.
Yeah, so it's about all types of radiation, right?
Yes, so these are the photon techniques. And what recently I have shown, the proton techniques, this is as well as very, very quickly developing. Both the imaging techniques, there are built-in MRIs where the patient is together with the table itself is transported to the MRI, and very frequently the changes can be controlled and adapted, the radiation, the because both the carbon 10 and carbon 11 are positron emitters, so a PET detector, positron detector, can be control the position of the patient after a small test dose, and so on. So both the controlling of the patient position, the target position, and the delivery itself, as I told, I showed a fixed beam, but nowadays a rotating entry is available, a breathing control is available, breathing grating is available, and raster scanning, which is much more accurate. So from the point of view of the used particles, because the proton therapy itself has a better property, better characteristic to provide selective irradiation, and as well as the technical development to really to use all of the technical possibilities to increase the accuracy.
Please, Doctor, I want to ask about the relapse percentage after proton treatment, and when we can reach to that point that we can say that it's enough using proton treatment and we are not necessary for chemical treatments together.
I'm not sure that I completely understood your question. The question was the amount of radiation, how we know that it is enough to destroy completely a tumor.
Because you know, normally after radiation and after this treatment, we could be in that place that some relapse will be happened. Yes,
Yes.
and sometimes it's not enough just to use proton therapy. We have to use chemical treatments together after surgery, of course. When we can reach to that point that it's good that just using proton therapy without chemical therapy.
I see, yes, I understand now the question. So, the radiotherapy is wise to use only for locally growing, local regional diseases. So if a patient has widespread metastatic disease, there is no sense to use radiotherapy unless if there are small number of metastases in the lung, in the liver, and that's it, or maybe in the brain. And all of these small metastases can be as well as treated with new methods of radiotherapy. So it is possible, but basically we use radiotherapy for locally advanced or localized tumors. And if we can achieve a complete response, the tumor is disappearing, depending on the tumor type and the capacity of growing back, there may be a possibility that we should not apply chemotherapy. But all of this, so in the oncology, everything is very well defined in the different protocols. So, for example, glioblastoma, this is a very malignant brain tumor. We know that if we seemingly destroy it seems to that they completely destroyed the tumor. The tumor has disappeared completely from the MRI images. Nevertheless, it will come back. So we know from clinical protocols which are the tumor types which are so aggressive that after seemingly complete destroyment, nevertheless may come back. So in that case, for glioblastoma, the temozolomide treatment after the radiotherapy, even in the case of complete treatment, is compulsory, mandatory, and we know from clinical trials that there were patients who have received from the STUP studies, it was published in 2006, that in comparison with randomized manner to use the postoperative chemotherapy and not to use, the patient had benefit and better survival and so on. So for each tumor type, for breast cancer, for everything, it is true that we are working on the basis of clinical protocols which are worked out, deriving data from strictly planned and controlled clinical trials. But coming back to your the other aspect of your question, if there is, for example, head and neck cancer, which we can completely diminish, and with follow-up images we cannot prove that it is existing at all, then there is no necessity to any chemical treatment. So we should try to be as effective as possible to destroying the local broccoli-germinal tumor. Okay, yeah.
So about chemical treatment, there are proofs that it is beneficial to humans.
For chemical treatment, that it is beneficial to use. Or
Yeah.
yes, we cannot use anything which is. We have to always not individually only balance the risk of a certain treatment and the benefit, but there are clinical data which proves that for that and that tumor type, that and that treatment is beneficial. I think in the recent decade, I can say decade, and in the recent years, there are a lot of development of molecularly targeted agent, the use of molecular targeted agent, and toxicity profile is completely different, and they are much more selectively targeting a certain molecule or certain surface receptor which is representative for the tumor. So it is there are different approaches and new approaches in the treatment of systemic treatment, let's say. Not only chemicals are used, and even the chemicals are much better and better. There are chemicals, there are chemotherapeutic agents which are metabolized to be an active agent in the tumor cells mainly. So there are tailoring of better selectivity and effectivity of the chemical treatment. And one last thing, that the immunotherapy, don't forget immunotherapy, the molecular basis, the checkpoint inhibitors, which have a great success in diseases where absolutely disastrous perspectives for the patients. For example, for melanoma, malignant melanoma, 20 later on, 40% of almost, I can say, cure rate would be achieved because the patients who had a good response to such like checkpoint inhibitors still in treatment and they are still living. Okay.
Yeah. And what about the cost of the treatment?
Enormous.
Like,
These new developments are very, very high. So there are a lot of calculations as well as for proton therapy and carbon ion therapy, and there are economical studies which are proving that fewer fractions and the recently available single room facilities are really rentable and even cost effective, but the chemotherapeutic agents, they are always used and used and used. So if there is a facility and to irradiate more patients, it is more cost effective. If you use a chemotherapeutic agent, you buy it always. But what is the price of the human life?
So the price of a chemotherapy is in the order of 100,000 euro.
Yeah.
Of a proton therapy in the order of, let's say, 20,000 euro. Of a conventional photon therapy in the order of 5, 6, 7,000 euro.
Yes, and if you treat more patients with proton therapy, the price is going down in a certain facility in a certain time range, at a certain facility in a certain time range, but for chemotherapy it's going up. But yes, it is not only the benefit of the pharmaceutical industry, it is as well as due to the fact that more and more strict regulation, more and more strict requirements are existing to prove the benefit for a certain agent. And there are a lot of molecules which are under study, and only one will be from 100 will become a patented agent which will give the benefit of a pharmaceutical industry. But you should not regret that's it. There are a huge difference. So if you can achieve complete cure with radiotherapy, you should do that. Okay, so thank you very much for this